A 58-year-old man presents to you for evaluation of right leg pain while walking. Denies any chest pain, shortness of breath, or any other symptoms. Past medical history of smoking for 30 plus years. Physical exam is normal except for decreased right dorsalis pedis pulses on the right lower extremity. Vitals are all within normal range. Total cholesterol is 170, HDL is 50, LDL is 98, triglyceride is 148. ABI on the right is 0.71, ABI on the left is 0.95. 10-year ASCVD is 6%. In addition to lifestyle modifications, which is the most appropriate next step? So the answer to this question, guys, is B. High-intensity statins, what should be given to this patient. This question is very important because it really highlights the difference between just approaching the patient just from a numbers perspective on the cholesterol panel versus overall risk reduction. So this guy, his LDL is not that high, right? But he already has a CAD risk equivalent. An ankle brachial index of less than 0.9 is how we diagnose peripheral arterial disease. And as you can see, it's 0.7 on the right side, where he is starting to exhibit some symptoms of claudication. So even though his cholesterol panel doesn't look that bad, the patient already has a CAD risk equivalent and therefore should be on a high-intensity statin. So this applies to patients also that may have a TIA history or CAD or stroke. All of those patients should be on a high-intensity statin unless there is a contraindication, okay? Ezetimibe is useful only if the patient's already on a high-intensity statin or a maximally tolerated statin and the LDL is still not at goal. That's when you would add ezetimibe, and it has been shown to reduce risk of events occurring if you already have a patient on a statin, okay? Ilarukimab is a PCSK9 inhibitor, so this is very effective in reducing the LDL, okay? It's an injectable. However, it's not first line, okay? It's not first line. This is only for patients who already failed statin or already are on a high-intensity statin and still have not achieved the LDL goal. So that's when this would come in play, but it's the wrong answer here. Fenofibrate is definitely wrong. This is only for triglyceride reduction, does not affect the LDL very much, and more importantly, does not reduce the overall risk. Remember, that's really what we're trying to do for these patients. It's not an issue of just fixing the number on the paper. We want to reduce the risk of having an event, stroke, a CAD, an MI, etc. Okay. Another thing that they could switch this question up, guys. So they could have given you a normal patient who just has some risk factors. Let's say they didn't give you this, and they said that the ASCVD is more than 7.5%. Well, in that case, it would still be high intensity statin. Okay. If they give you the patient that has an ASCVD above 10%, that's very high risk. Those patients should be on a high intensity statin, as well as aspirin 81 milligrams for primary prophylaxis, okay, as long as they don't have a contraindication. Moderate intensity statin is a good idea in patients that don't have CAD risk equivalents, but have an ASCVD above 5%. So this patient, for example, if they told you that all of these tests were normal, he does not have any evidence of CAD or PVD, then since his ASCVD is above 5, you can consider a moderate intensity statin in that patient. I hope you found this helpful. If you have any questions, please post them in the comments.